Thank Thank you. Good morning, everyone. Thanks, organizer, for giving me this opportunity to speak on fungal infections post-kidney transplant. With a good advancement in the immunological tools and reduction in the rejection rate, what we are now facing is a mortality with the functioning graft. And the second most cause of the mortality with functioning graft is infections. And amongst the infection, the fungal infections are becoming more and more challenging. Since we have good vaccination before transplant, we have good prophylaxis with antiviral and antibacterials. What we are facing in kidney transplant is the emergence of the fungal infection, mainly the invasive fungal infections. And the most important cause of the fungal infections in kidney transplant, if we see the almost 80% are caused by the Candida and Aspergillus, and the remaining 20% are because of the Cryptococcus or other molds which are causing the post-transplant fungal infections. The basic principles of the infections post-transplant is it is sometimes very difficult to have a clear-cut signs and symptoms. Patient can have a very bad infection and still will not have any major symptoms. And there is also decreased sensitivity to investigation modalities like serological investigations or radiological tests. And sometimes patient can come with a devastating sign like mycotic aneurysms or a big fungal node and with minimum signs. So it doesn't give you time. So this is very important. We should keep our eyes open and have high index of suspicion when we are treating these patients. The other things which we face is related to treatment. We have CNIs which can be increased by rifampicin or can decreased by rifampicin, or there can be very high CNI level following azoles. Also, there is synergistic nephrotoxicity with many drugs like aminoglycoside, amphotericin, and cotrimoxazole. So we have to keep all this in mind when we are treating a transplant candidate for infection. Preferably patients who are immunocompromised, and when they are having an invasive fungal infection, the things which we face or the challenges which we are facing these days is there is changing epidemiology of this infection, there is a non-specific presentation, there is inadequate diagnostic methods and tools. The antifungal prophylaxis, it is still not recommended in patients who are on kidney transplant, and whether they are effective or not. So there are, the guidelines are still not there for the antifungal prophylaxis in kidney transplant recipients. There are breakthrough infections of the antifungal, on patient on antifungal, and there are sometimes refractory to antifungal therapy. So these are the challenges which we face. And the immunocompromised host, their number of immunocompromised hosts are increasing day by day. The pool is increasing because of number of patients who are going under transplants have increased significantly. There is a lot of use of antibiotics which is causing them prone to the antifungal, prone to the fungal infections. There are newer and more potent immunosuppressant agents are available, which is making them sensitive to the fungal growth. And immunocompromised status because of so many other reasons. The mortality of fungal infections, mainly aspergillosis, is related to the state of the type of transplant or the patient's immune status. So if you can see the liver transplant and bone marrow transplant, they have a highest mortality. But even in kidney transplant, the mortality is as high as 60 to 70%. So higher is your compromised defense, higher is your chance to get multiple fungal infections. So if you are severely compromised, you are likely to get multiple fungal infections, not only single. So the net state of immunodeficiency depends on the current and past immunosuppression. Patients who are presently on low immunosuppression, but if they have received very high dose induction, or if they have received rituximab high dose, they are likely to go into the fungal infection possibilities. Then prior therapies with chemotherapeutic agents or antibiotic, there is breach in the mucocutaneous barrier either because of the catheters, lines, or drains. The neutropenic or lymphopenic state of the patients, underlying immune deficiency status like hypogammaglobulinemia or lupus, patients who are having metabolic risk because of the uremia, malnutrition, diabetic or cirrhotic patients, they are at higher risk for net state of immune deficiency, and coexisting viral infections, mainly CMV, which can lead them to the more immunocompromised state. The greater infection risk post-transplant is one most important is, of course, induction therapy, high dose of steroids, plasmapheresis, higher rejection risk, patient having sensitized host, and higher rejection risk having higher immunosuppression. Early graft rejection treated with high dose immunosuppressions, graft dysfunction, and active or latent either donor or recipient infections. These are all the risk factors. And the technical risk are the patient having an anastomotic leak, bleeding, wound infections or poor wound healing, and prolonged intubation or ICU care, and of course breach in the either because of the vascular or urinary catheters. So these are the risk factors. The patients which we would like to have and which are having low risk are the good HLA match, technically successful surgery, good graft function, appropriate surgical prophylaxis, effective antiviral prophylaxis, and PCP prophylaxis, and appropriate vaccination pre-transplant. These are the class of patients which would have a very low risk and would have a less chances of fungal infection. If we see the timeline for the post-transplant fungal infection, as in bacterial infection, less than 4 weeks we usually come across with Candida. In 1 to 6 months, the Candida and Aspergillosis or sometimes Cryptococcus. And post 6 months transplant, we see Aspergillus, atypical modules, mucor. All these are the infections which we come across after the 6 months post-transplant. As far as clinical symptoms are concerned, usually they may not come with the typical symptoms. There will be vague symptoms, or patient may not have any symptoms, and we have to keep a high index of suspicion to diagnose these patients. They can have unexplained fever despite broad spectrum of antibiotic. Patients are treated with broad spectrum and they keep coming back, and that is the time which we have to suspect that yes, there might be underlying fungal infections. Recurrent febrile episodes, pulmonary infiltrations, cough, fever, hemoptysis. These are the symptoms which patient can come with. When it comes to the diagnosis, culture is of course the gold standard. Other than culture, the other detection methods for the diagnosis of invasive fungal infection is a serological test, which can be either galactomannan or beta-D-glucan. We can have mannan and antimannan antibodies. Then comes the PCR-based assays. We have a lot of PCR-based available for many of the fungi these days, and imaging. Something about the beta-D-glucan, it is a cell wall component, wide variety of fungi having it, except for zygomycosis and cryptococcus. It is indicated for the presumptive diagnosis of invasive fungal infection. It has a very good sensitivity with good negative predictive value. So it is helpful excluding the fungal infection. So it is a good predictive, negative predictive value. In a review of 23 and a meta-analysis of 16 studies, containing around 3,000 patients, the sensitivity of the test was almost 76.8%, and specificity is 85.3%. Similar analysis also showed 80% of sensitivity and 82% specificity. So it is a good test. In a 487 fungal infections post-transplant study, as you can see, the Candida and Aspergillus are the main, and other fungi cause less infections. When we classify the fungal infection, they are classified into the either superficial, cutaneous and subcutaneous, and deep invasive fungal infections. In kidney transplant recipients, the fungal infections like Candida is around 49 to 61%. Aspergillus contributes to around 11 to 14%. Then Mucorale and other molds around 2%. And usually we don't see fusariums in a kidney transplant recipient. Something in short about the Candida, it is most common infection, and it is a colonizer of the gut, respiratory and reproductive tract. The most common symptoms of invasive candidiasis are fever, chills that don't improve after the antibiotic treatment for suspected bacterial infection. And other important, other symptoms can develop if patients develops a tissue or invasive fungal infections, either of the heart, brain, eyes, bones. So depending upon the system involved, we will get the symptoms. Then comes aspergillosis, which is the second most fungal infection which we see. Patient can have allergic bronchopulmonary aspergillosis, or sinusitis, or fungal balls, or they can come with the chronic pulmonary aspergillosis. X-ray is a good tool to identify the aspergillus. Patient can have nodular lesion or interstitial opacities, or pulmonary embolism pattern, or sometimes can be a normal chest X-ray. When there is a normal chest X-ray, or in early stage, CT scan is more valuable. It can pick aspergillosis almost 5-6 days earlier than any other modalities. As you can see in this patient, the fungal opacity and chest radiogram is seen behind the heart, but in CT scan, we can see good cavitating nodule in the left lower lobe. Mucormycosis is seen usually in the later stages of transplant. We can have a cutaneous lesions or pulmonary mucormycosis or rhinocerebral causing sinusitis or black lesions on the nasal bridge or on the palate. And sometimes, rarely, we can see GI mucormycosis. Cryptococcus usually we see after 6 months post-transplant. It can usually cause meningitis or pneumonia. There are rare fungal infections like zygomycosis and all this. They cause fungal infections into the pulmonary system. And then we have trichoderma and other cutaneous fungal infections. These are rare fungal infections which we come across in post-kidney transplant patient in 1 to 2% cases. Diagnosis, most important bedside is a KOH preparation, which is having good sensitivity screening test for the rapid detection of the fungal element. Blood culture or culture from the tissue fluid, either CSF or retinal fluid, is another gold standard. Then comes the quantitative test that directly detects the protein products or nucleic acid of the particular organism. The galactomannan assays can detect aspergillosis before even symptoms come. Having a baseline galactomannan test, and once we start treatment, monitoring the galactomannan to know the response to the treatment is a good tool. So if the titers are falling or increasing. Invasive procedures should be done well in advance. If you are thinking there is a fungal infection, BAL or any tissue sample has to be taken well in time so that we can treat patient in time. Imaging studies have limited roles. We can have CT, USG, X-ray chest, everything, and which can reveal pulmonary infiltrates, hydronephrosis, fungal balls, or we can sometimes give perinephric abscess, which can suggest a transplant failure with this kind of fungal infections. There are certain emerging fungal infections or rare fungal infections which we see in solid organ transplant recipients, like this Malaysia, which is causing pityriasis or tinea versicolor. Then we have rhodotula, which causes peritonitis. Then these are endemic fungi, penicillium and peracocet. And this portrix is initiated by the trauma, and it can become an invasive fungal infection. So these are very rare, but emerging fungi which we see in our transplant recipients. Now we see about the antifungal agents. So the antifungal agents, every decade we are having two or three new antifungal agents which are added to our armamentarium, and we have a full basket of antifungal agents after 2000. I would briefly comment on the treatment also. The candiduria, the fluconazole is a drug of choice which we give 200 to 400. What is important is the duration of treatment in fungal infections. So in candiduria, we have to give for several days before and after the procedure. Candidemia, fluconazole loading dose is 800 and then continue 400 milligram per day, 14 days after the negative blood culture, first negative blood culture. For aspergillosis, voriconazole 4 milligram per kg until all signs and symptoms of infections have resolved for at least 2 weeks. For cryptococcus, fluconazole 400 milligram per day. It can be combined with flucytosine usually, and it is to be given for 6 to 12 months. And mucormycosis 5 milligram per kg per day of liposomal amphotericin B until patient exhibits a favorable response. The antifungals I would touch in brief. The amphotericin B, that is conventional amphotericin B, which is a deoxycholate. It is a Pauline compound, broad spectrum. It is a nephrotoxic drug and not recommended as a first line. Liposomal amphotericin B is a lipid-associated formulation. It is indicated for the treatment of severe systemic mycosis and can be used empirically in suspected fungal infections or fungemia. Then comes azoles, which inhibits CP450 and it increases CNI level significantly. So whenever we are using azoles, we should adjust and monitor the blood levels of CNIs. Voriconazole is useful in aspergillosis and it can be used in M4B resistant fungal infections. Then comes fluconazole, which is most widely used antifungal, useful in prophylaxis and treatment of superficial systemic fungal infections. Itraconazole has a wider spectrum than fluconazole. It is active against both yeast and molds. Posaconazole, it is a newer antifungal It has been used for prophylaxis and treatment of invasive aspergillosis and candida infections in patients who are more than 13 years. It is only found in oral formulation and is predominantly eliminated in the feces. So we don't need adjustment of dose in renal or hepatic impairment. Echinocandins are the newer antifungals which are available. They are a little costlier, but having very good spectrum and very good response to the treatment. They work by disrupting the biosynthesis of glycan polymerase in the fungal cell wall, and that's why we can monitor the treatment of these echinocandins. The drugs available are mycofungin, as effective as a fluconazole and possess as an alternative for the antifungal prophylaxis. Then comes the caspofungin as an empirical therapy for presumed fungal infections such as candida or aspergillus in febrile neutropenic adults. Anidulafungin, it is important thing about it is that it is not metabolized by the liver or kidney, so we don't need to adjust the dose, and has a wider spectrum of action and lower toxicity profile. Something about flucytosine, it is useful in treatment of systemic fungal infection caused by either candida or cryptococcus. It is known to cause rapid emergence of resistance, so it is always given in combination with other antifungal agents, usually fluconazole, so that resistance is not there. Nystatin is locally acting, and that is the only drug which has been recommended in prophylaxis for the kidney transplant recipients. So to summarize, diseases caused by these diverse fungi are collectively known as emerging or rare fungal infections. Renal transplant recipients usually present with vague clinical symptoms or infections. The diagnosis of fungal infection in transplant recipient can be very perplexing, and due to vague symptoms and no clear-cut signs or even the investigations. And treatment of emerging fungal infections can be very challenging. So elements to success to treat the fungal infection is suppression of fungal growth, recovery of host defense, and repair of organ damage. Thank you for patient hearing. Thank you.